All right, good morning, everybody. Welcome to another edition of the AFR EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue. And today I'm joined by our Medical Director, Dr. Kimberly Pruitt.
Hi, Chief.
Welcome, Doc. And we're also joined today by Lieutenant Vindog, Vinny Cordova, the man. Thanks for coming to talk with us.
Thanks for having me.
Today is an interesting case and a lot of unique perspectives on ways to handle it. So I wanted to talk through. There was a traumatic injury. You were assigned to Rescue 4, right? And you guys got dispatched out to a 30 Delta, which you know is a traumatic injury. What information, if any, did they give you on the dispatch to this 30?
So when we got dispatched to this one, they didn't give us a lot. I think the notes were really tough. The location was even tough also. So we knew we were going to this. We knew we were going to the cemetery, and cemetery's big. So we knew we had an impaling. That's all we knew. So while we were driving, we're like, okay, well, what side are we going to be going to? We're trying to get on. And we know that the cemetery is locked. So there's usually only one way in. So we found that one direction to get in, and then we started looking for our patient. So that's kind of the initial size up, the initial things that were going through our head on the way. Yeah.
That's a great point. And there was the cemetery that's along Manal, so we know it has a lot of metal fencing around the entire perimeter, pretty big facility. Was it day, night?
So it was daytime.
Okay.
Yeah, it was daytime. And like you just talked about it, a lot of the homeless population kind of takes a shortcut. And I think they tried jumping over that fence, and they're constantly going through there. So that's why all the gates are usually locked.
Gotcha. Okay. And so on arrival, you get there, you finally do locate the patient. Tell us, kind of describe what you saw, how the patient was presenting.
Okay. So so we found the patient, and we're pulling up. So right away, we kind of did a like a radio size up to let everybody know what we had. Hey, we found the patient. This is where he's located. It looked to me like he was trying to jump over the fence, but when he jumped over, one of his legs got caught at the top of the, around this fence. They're about half-inch metal pickets or metal posts. One went right through his leg. So it was actually, he was downward, kind of holding himself up, and it looked like he had been struggling for a while. There was a pile of blood that was just right underneath, so he was bleeding for a little bit. And he was trying to get his leg out. You could tell that he had been just back and forth, and when we got there, he was exhausted. He was tired. Started to talk to him. He was talking to us. He was alert. He was oriented, but he was just pale, diaphoretic. You know, he had probably been sweating the whole time. I don't think he had a cell phone on him, so I'm pretty sure somebody else called it in. It's weird they didn't stop and try to help him or hold him up. So we got there right away, and we had our first guy. We're like, hey, hold him up. Let's hold this guy, because he couldn't hold himself anymore. And every time he would push, he was just pulling his leg, out of the picket. So that hole, or where he was impaled, was just getting bigger and bigger. So we kind of right there, we're like, all right, let's slow down. Did our little size up. Once we did our size up, we're like, okay, this is what we want to do, guys. So first thing is, let's get our pressure bandage, get some Curlex out, let's get ready. And then we talked to him. He goes, I'm in pain, and he's just screaming. So I said, all right, let's give him some fentanyl. I think that was a good choice, just for the pain. So we did 50 IN, gave it to him. He had no relief, but our what we were thinking right there is, okay, are we cutting this, or are we just going to try to pull him off? So Station 4, our whole station was practically there. Everybody heard the call. Everybody wanted to go to it. So we had tons of hands there. 5-5 was showing up right at that moment also. So we gave him some fentanyl. We're like, okay, let's get him out. It didn't look like the picket, the metal picket, was holding any sort of pressure or stopping anything from bleeding. So at that point, we had enough hands where we said, all right, let's just pick him up. And when we pick him up, we'll put him right on the gurney and go from there. So we slowed down, we stopped, we got our tourniquet out, we put it on, and we said, okay, we might pull this thing out, and a bunch of blood might come rushing out. If it does, we need to be able to, clamp this thing down as tight as possible. Yeah. So put the tourniquet on him, we got ready, we had a couple people with the bandage, Curlex ready, and we said, all right, let's go. And so we literally just picked him up right over and put him right onto the gurney, tightened up our tourniquet, put our pressure bandage on him, and then wrapped him up. I felt like that was the best bet for us. And we did consider just cutting it. We got the HTR station, we got all the tools there, and it wouldn't have been much for us to cut it, but that would have just taken a little bit longer. It would have been loud. And when we weighed out the situation, we didn't think we needed to, which was good.
And we talked about that. Had it been like a more fortified part of the fence that wasn't moving, more rigid, probably would have tamponaded better. But since this one was loose, even just thinking through, if you were to cut it, now you have this dangling piece that's really not serving a purpose anyway.
Right.
So I think it was a good decision to do that. Doc, talk through us if we encounter that situation with something more fortified and why it's important for us to leave it in place if we can and it's feasible.
Yeah, so the classic teaching is to cut around it and leave the impaled object in there with the idea that it's probably tamponading whatever massive bleeding may occur if it's removed. But in this case, it was pretty clear that this object wasn't helping stop bleeding. It was fairly loose and easy to cut, so the most practical thing was to still prepare for a massive hemorrhage, which you did great, and then go ahead and remove it. I think extremity hemorrhages are a lot easier to control if this was something that, let's say, was impaled in the abdomen or the chest. Those are places where you would probably want to leave the object in place and cut around it, but in this case, you could control the hemorrhage. The object didn't seem to be helping, and it was going to be easier and quicker just to facilitate his movement without the object in place.
Yeah, no, exactly, and that's what went through our mind. If we would have just cut that right there, I think it would have just fallen right out.
Yeah.
So.
Yeah, it was excellent decision making on the spot with a complicated presentation, and I'm really glad to hear that you anticipated you had the tourniquet in place, even not necessarily tight, but before you knew it was probably going to bleed when you pulled it off, and you were ready for that,
right.
And had everything in place so you could apply it quickly when you needed it.
Right. Yeah, that was something we wanted to kind of stop. Hold on, make sure this is on.
Yeah.
And I think that was good.
Yeah.
Looking at the chart, the initial set of vitals that you got, my assumption is that's after removal from the fence. Heart rate was at 111. Pressure was still good, 106 over 68. Satting well. Respiratory rate was fine. Capno was good. Sugar was good. So really we were worried about that blood pressure. And you guys had a decent blood pressure, and that was part of your thought process, you said, of not seeing a huge gush of blood and realizing he was still vitally stable.
Right.
So that was good. So talk about we did the initial dose of fentanyl when he was still up there, and then we moved him. Did we give additional doses of fentanyl afterwards?
So we just gave the one. So we didn't end up writing with this patient here. We ended up putting him on. Great. Checking another set of vital signs. Awesome. Starting a line. All right, let's get this line going. Start giving him some fluids. We know he's already lost fluids. We got to start supplementing that. And then we said, all right, what do you guys need? And they were like, no, nothing. They had a paramedic student. So AS had a paramedic student with them. We let them start the line. And there was just plenty of hands there. So once we got him stabled, ready to go, okay, let's go. And we weren't too far from the hospital also, so it was a pretty quick transport.
Yeah, straight shot to the trauma center. Doc, you were familiar with this call after reviewing this. What happened with that patient when they arrived at the ED?
Yeah, so he did show up with a pretty hypotensive. So he was in the 70s. And what they were worried, he did get transfused on arrival because they suspected bleeding with his obvious injury. He had an open fracture. So he actually impaled himself enough to fracture his fibula. And he had some little bleeders in between his legs. So after they transfused him, they took him straight to the OR to cauterize some of the bleeding and get him on the antibiotics and do the orthopedic repair. But it's pretty severe injury.
Oh, yeah.
But you guys did a great job controlling his hemorrhage and getting him to the hospital right away.
Yeah, acted fast. It was decisive, and you guys did a fantastic job. In hindsight now, these are rare calls. Rarely we see these, but it is a potential for them to happen. Looking back, or if you had this call tomorrow, is there anything that you would do differently or keep everything pretty much the same?
Honestly, probably not. I felt like everybody was on the same page there. When we got there, we did a good size up. We thought about it. We slowed down. I think I would have handled it the same way, to be honest. No, there's nothing that I would have changed. No, I don't think so, man. I think that was the way to do it. I don't see a better option. If circumstances were different, then yes, maybe. But it was tough. It was tough because the way that wall is it's a wall. So it's a brick wall, and then on top of the brick wall are the pickets, and those pickets are probably 4 feet plus. There's another 3 feet. This is a 6 or 7 foot wall. So. When he was up there, we had our guys on top of the wall kind of holding on to him and to the fence themselves. So I think just getting him off as fast as possible was the best option there.
I think so too. And I was thinking through the fact that you were there with the HTR group, like all of you were trained in heavy technical rescue. You have the squad there, so you have them to be able to pick their brain and see what they want to do. But thinking through this, if this call was to happen like in 16s and seeing how quickly that patient deteriorated from the time that you had him to the time he got to the hospital, he became hypotensive. So a good decision point for those, remote officers, Rescue 22, Rescue 16, to make the decision. Do we call out the squad in order to cut this, or is it most beneficial for us to just move this patient and then get them to definitive care? So hearing your story, I think is going to help a lot of those folks out there, because you had the luxury of having all the team there in one shot. But I think it was a great decision and ultimately helped this patient and potentially saved his life because of his hypertension.
Yeah, I think if he'd been hanging there much longer, he probably would have bled to death.
Yeah, I agree.
And we, as like the EMS division, we're looking at different products that are available, to like tourniquets that we want to kind of look at that that are now commercially available to be able to even be better than the ones we currently have. So we see the trauma, especially this summer. So I think having those tools in our toolbox are going to be super helpful and help the patients. So. Fantastic job, dude. I really appreciate you taking the time to come and talk to us about it.
Thank you for having me.
That's it for today's case study. If anybody has an interesting or cool case like Vindog, then I want you to submit that through the SharePoint tab. Or you can reach out to the EMS division or your 7-8 and come and talk to us about it. I appreciate you, and until next time, thanks.